Welcome everyone. For those that don't know me, my name is Linda Cam. I'm a pharmacist at the VA hospital, and today I wanted to talk about antiretroviral drug interactions. We actually have a clinic at the VA, and we deal quite a bit with HIV patients, so we do see quite a few of these drug interactions. So I want to talk about how we can use some of these drug interactions to our advantage, and then things to look for if they're going to be problematic drug interactions. So when we manage an HIV patient, obviously there's some co-mediators or medicators. We're not just in a silo here because we're managing their HIV, but there's also other things that these patients come into with, and because our patients are living longer, they have other disease states that come into play besides our opportunistic infections. A lot of them are living longer with metabolic disorders, malignancies, drug dependence, psychiatric disorders, and neurologic manifestations. So when we talk about the pharmacokinetics and how these drugs work in these patients, there's some things that I kind of wanted to highlight here. We're going to talk more about these in detail: drug absorption, how these drugs are absorbed, metabolism of these drugs, P-glycoprotein and where this plays in the absorption or distribution of some of these drugs, protein binding, excretion, and then this new phenomenon with the polymorphism, pharmacogenomics, individuality. We're seeing more and more of that, and we're learning more about that and how it impacts some of the drugs that we use in our patients. So to start, I want to talk about drug absorption. Excluding enfuritide or T20 injections, all antiretrovirals require gastric absorption. The rate is not a significant factor as compared to the extent of the absorption because this is a chronic disease, so we don't need the rapid onset of action with, unlike some of our other infections. Some of our HIV patients have achlorhydria, so that may hinder the absorption of these medications. Some drugs actually require a gastric pH for the absorption, so we tell our patients to take it on an empty stomach or space it apart from acid-suppressing agents. And examples of this would be Darunavir, Darunavir, and Atazanavir. On the other hand, some drugs require taking it on an empty stomach because it requires an acid-labile system. DDI, didanosine, would be an example of that. And in the old days, we used to give didanosine with a bicarb supplement because the acid actually prohibits the absorption of the medication. Darunavir, unboosted formulation, is also given on an empty stomach because of the enhanced absorption. The newer agents on the market now are much better in the terms of absorption because they realize how difficult it is for some of these patients to remember which medication to take with food, which one to take it on an empty stomach. So some of your newer formulations are better in terms of not having some of these properties. When we talk about metabolism of some of these drugs, there's basically two ways the drugs are metabolized. Either through a phase 1 metabolism, which includes reduction, oxidation, and hydrolysis, or ROH mechanisms. They go through a cytochrome P450 isoenzyme system, which we're very familiar with. And through that, they can actually induce metabolism of drugs or inhibit metabolism of drugs. Normally, the induction process takes days to weeks to see. So as soon as you put a patient on a drug and there's a drug interaction, you may not see the effects or the levels increase or decrease for several weeks out. On the other hand, if it's an inhibition process, this is more of an immediate effect and you will see the reaction take place right away. So the one we're most familiar with is the cytochrome P450 3A4 isoenzyme system because this makes up the largest fraction of the enzyme system. As we know, it's not just in our gut, but we also have it in our liver and the small bowel. The other process, glucuronidation, is a phase 2 metabolism, and you might have heard of the UGT1A1 enzyme, because this is kind of new. And with Raltegravir, one of the agents that we use in HIV, this is believed to be the process that it uses for metabolism, and therefore does not have some of the drug interactions with some of the other medications that use the isoenzyme 3A4 metabolism system. This is just a picture diagram depicting what happens in our system when we have an enterocyte here. The parent drug is metabolized to metabolite in our enterocyte through the 3A4 system. There are these proteins called P glycoproteins, which actually can work a couple of ways. It can work as a transmembrane, so it carries drug into the portal system, or it actually works as an efflux system, and it actually can eject drug back out and reduce the absorption. And it's believed that there's some individual intervariability in the P glycoprotein. So some of us may have more P glycoprotein and some of us may have less, therefore altering the absorption of the drug. And then in the liver, what happens is a similar kind of thing in a hepatocyte. Your cytochrome P453A isoenzymes from the portal system can transport the drug or metabolize the drug into the systemic circulation. And this is demonstrating the two different systems that I alluded to earlier. Phase 1 on top, using reduction, oxidation, hydrolysis, and then here at the bottom using glucuronidation in a phase 2 metabolism. So P-glycoprotein, as I touched on just a minute ago, it's a transmembrane. It can do a couple things. It can transport medications through the membrane in the enterocyte, or it can actually act as an efflux pump and pump drug out of the system. It's encoded by the MDR1 gene. It's actually expressed in epithelial cells, so it's not just in your GI tract, but in your liver, kidney, blood-brain barrier. There's been some G-glycoprotein isolated there as well. There's an example of azoles may inhibit G-glycoprotein activity. So we're learning more about this protein and how it affects drug absorption and metabolism. Excretion. When we talk about excretion, we're mainly talking about renal function and how patients excrete the medication. Some drugs actually can increase the time that the medication is in the body because it's inhibiting tubular secretion. An example of that would be like probenecid. If a patient's on probenecid along with some other medication, an example here I gave is AZT, you're actually increasing AZT area under the curve when you give them probenecid. Kind of what happens when you give a patient probenecid with penicillin, for example, and we used to do quite a bit of that. When we look at efficacy of drug, some drugs actually work synergistically. So if you combine one drug with another good drug, you get more than an additive effect. You get more a synergistic effect. And we used to believe that if we use DDI with hydroxyurea in HIV, we actually got a synergistic effect. However, that's no longer used because the latter studies have proven that this combination, although it does give you a synergistic effect, the outcome of those patients who were put on DDI and hydroxyurea were not optimal. So we no longer use that, but if you look at the science behind it, they do provide a synergistic effect in HIV, but in vivo it did not prove the same. And then other combinations like abacavir and mycophenolate have also been proven to provide a synergistic effect, although we don't use that routinely. And then agents that actually provide an antagonistic effect, and therefore you never want to use these drugs in combination, would be example of the AZT and D40. And I remember in days when we used to do that because that's about all we had. AZT ribavirin is another example. You don't want to use these agents together because of antagonistic effect. And then DDI and tenofovir. If you use it, you have to use it dose adjusted. The DDI has to be dose adjusted because of the antagonistic effect. Some drugs actually give you an additive toxicity when you use them in combination in HIV patients. So an example would be AZT with ganciclovir because it causes enhanced bone marrow suppression. DDI and D4T, we used to use that quite often together. We probably don't use it that much anymore though, and it can cause things like peripheral neuropathy, pancreatitis, and lactic acidosis. Um, if you did a PubMed search or a Google or Ovid search, you'll find a lot of studies looking at antiretroviral drug interactions. However, it's important to realize a lot of these studies that were done, may have been done in vitro. It's very hard to do in vivo studies looking at drug interaction because there's so many different factors that come into play, and it's so hard to pick the exact patient population to do your study. Most of the studies that look at PK or PD in HIV patients have used healthy volunteers in the past when they looked at this data, and how does that relate to HIV infected patients? So, there may be some differences in variability because of the polymorphisms we talked about and things like that. So it's very difficult to extrapolate that exclusively to HIV infected patients. Also, we know that in HIV infected patients we have some variability in the CYP3A4 isoenzyme activity. So again, very difficult to extrapolate. And then ultra drug metabolism in HIV patients, we know that. So we would have to do a study, PD study, strictly in an HIV patient, looking at kinetics and drug interactions, and taking into account all the different variabilities, and therefore it's very hard to do. Also, in the literature, there's single dose studies looking at PK, and then single drug. But how many of your patients are on a single drug? So it's going to be very difficult because there's different drug interactions, different combinations that can be used, and how do these drugs affect each other. So the next thing I'm going to do is I'm going to try to take each class of medication and then break it down into the sort of things you need to look for and consider when you're using these drugs, and just highlight some similarities and differences amongst the classes. So starting with NRTIs, or nucleoside reverse transcriptase inhibitors, we said primarily they are tuberally excluded. So many of them require renal adjustments in patients who have renal dysfunction. AZT actually goes through the conjugation process. AZT and D4T go through what we call a competitive phosphorylation process with the metabolism. And I think I touched on this earlier. If you're going to use DDI and D4T, that there should be a dosage adjustment if you're using those in combination. If you're using NRTIs with Atazanavir, it actually reduces the Atazanavir area under the curve, so you always want to use it pharmaco-enhanced with the Ritonavir. And I think for the most part, everybody that's on Atazanavir now is on a boosted Atazanavir. We rarely, if ever, use Atazanavir unboosted anymore. So that kind of solves that. CYP interactions are not regularly encountered in your NRTI class, so that's usually not a problem if you have other drugs that are metabolized through the 3A4, because these are renally cleared and they go through intracellular phosphorylation. Okay. If you're using NRTIs with non-HIV meds, again, think renal, and I've highlighted that in red for you. So things that may decrease phosphorylation would be example with ribavirin. If you have a patient who may be Hep C positive or something, you're treating them with ribavirin and their HIV at the same time, you need to think about that. And then with methadone, it's kind of tricky. It kind of goes up or down. I've seen it both ways actually in patients. So you just got to be very careful with that one. Some of the patients require an increase in their methadone requirements, and some actually have a decrease because they're really sedated, and they would require a reduction in their methadone requirements. With NNRTI, Again, this is an extensively hepatic metabolized drug. It does go through CYP isoenzymes. Your inhibitors would be your efavirenz and delavirdine. And with etravirine, it goes through the 3A4. It's an inducer with etravirine at the 2C9 and 2C19. So this one's a little bit trickier. Sometimes it works as an inhibitor and sometimes it works as an inducer, depending on the isoenzyme. If you're going to use efavirenz, it does require pharmacoenhancement when used with Atazanavir. So again, going back to when you use Atazanavir, the majority of our patients are on boosted Atazanavir because of the drug interaction and also because of enhanced PK levels with the boosting. For the most part, everybody's using Atazanavir boosted now. In NRTIs, primarily a hepatic drug. You can see lots of drug interactions with NRTIs. Here's a list with efavirenz. Because it can act as an inducer or inhibitor. You're going to have interactions with ergots, cisapride, benzodiazepines, rifampin, rifabutin, macrolides, warfarin, methadone, and then azoles, voriconazole, itraconazole. So if you're using efavirenz, these sorts of drugs should kind of go off as bells in your head to look for potential problems. Nevirapine, on the other hand, is strictly an inducer. We like to say efavirenz can go both ways, kind of, if you will, and then the others aren't so much. Nevirapine is strictly an inducer, so if they're using oral contraceptives, they need to use alternative forms of birth control. Rifampin, ketoconazole, and methadone. And then delavirdine, I don't know if anybody has much experience using that, but we don't use it a whole lot anymore. It's strictly an inhibitor, and it interacts with some of the similar agents that we have with efavirenz. So the one I think most of you in here are familiar with is probably efavirenz, and then every now and then you'll probably have a patient on nevirapine. Is that about right? So protease inhibitors, think 3A4 here. That's the primary metabolic pathway. Ritonavir is greater or more extensive 3A4 than Sequinavir, Tipranavir, and then least is Atazanavir. Lopinavir, Ritonavir, and nalfinavir have also been associated with induction, but probably less than any of the in the top row, and I probably will associate these two with kind of Atazanavir because we're using low concentrations of ritonavir here with a lopinavir. It's no longer really a factor. PIs are also substrates and potential inhibitors of P-glycoprotein, so just be aware of that. If you're using PIs with non-HIV meds, think hepatic. So you're going to have interactions, and you want to avoid using in combination with some of the similar things we saw in the previous slides with NNRTIs, ergots, benzos, rifamycins, the statins. So if you're using a statin, you want to avoid the hepatic eliminated statins, and you want to use the renally cleared statins like fluvastatin and pravastatin. You can use those safely, but if you're going to use it with simvastatin and lovastatin, you may run into problems. Okay? Phenytoin, phenobarbital, carbamazepine actually can decrease protease inhibitor levels, and it can increase carbamazepine levels. And then over-the-counter or herbals, St. John's worts and garlic are problems with PIs. So we always try to tell our patients not to use St. John's wort products with PIs because of the drug interaction. And then I was able to find this study. Is a small study, but we don't really talk about rifabutin that much with PI use, or if it's a TB infected patient. The guidelines actually recommend using rifabutin over rifampin, or if it's a MAC infected patient, we use rifabutin in our HIV patient. But this study, although it's a small study, in 2009 CID, they actually observed failures in 9 out of 10 patients who are on rifabutin with boosted lopinavir. And it was because of the rifabutin levels being really low and causing rifamycin resistance. So just keep that in mind. There's not a whole lot out there, but there is a potential interaction with rifabutin and Kaletra. I don't know what happened to my heading there, but on the left it was supposed to be Sequinavir, and then on the right it was supposed to be can't remember what it was supposed to be. I think it was Nelfinavir, I think. Indinavir, 60% protein bound, so that may be a problem. You're displacing a lot of free drug there because it's 60% protein bound. It's got a short half-life, secondary to a high systemic clearance, and it prefers a gastric pH. So in the old days when we had a lot of patients on Indinavir, we used to always try to tell them to take it on an empty stomach if possible. Nowadays we don't use too many. We don't have too many patients on Indinavir anymore. I guess only those patients who've been stable on Indinavir and then have continued to stay on it. If you are using Indinavir, though, and you're using it in a patient with efavirenz, you need to increase your Indinavir dose to a gram Q8. And if you're using Indinavir with your azole, ketoconazole, or itraconazole with the laverdine, you actually need to decrease your Indinavir to 600 Q8. So there's a couple of little caveats if you're using it in combination with other products. We know Ritonavir is our pharmacoenhancer. We use it mostly with a lot of our PI regimens now. We used to use Ritonavir as a PI, but you need to have such high doses of it with such high toxicities that we no longer use it as a PI anymore. We mainly use it as a pharmacoenhancer. And then the other reason was the significant drug interaction. So we used to use, I think it was like 600 BID of Ritonavir. So it had a lot of drug interaction and a lot of side effects because it was such a high dose. Always err on the side of conservatism with Ritonavir, and there's a couple of references I'll give you at the end. Very good references for looking up drug interactions, HIV drug interactions. So lopinavir, Ritonavir, because it's got the Ritonavir component in it. I think I touched on drug interactions with efavirenz. You actually, instead of 2 tablets BID, you have to increase the Kaletra to 3 tablets BID if you're using it with efavirenz. 600, 150 BID. And if you're using it with nevirapine, you should avoid the Q-day dosing. So instead of the 400, you need to split them up into BID dosing if you're using it with Kaletra. Don't use Kaletra with Pharm.D, and then increase levels of fluticasone adrenal suppression if you're using it with Ritonavir. So you got to be careful with that as well. And then for our new malaria agent, artemisinin, it actually causes increased levels of artemisinin if you're using it with Kaletra. And induction of phenytoin metabolism, the lopinavir can do that with phenytoin. Pharm.D, again, we're seeing probably less of this agent being used anymore, just because of the pill burden and we have better agents available. Some people used to be on multiple PIs, but if you're using Pharm.D, it's not recommended to use combination PI regimens because of drug interactions. Atazanavir, which many of you have lots of experience with, it's not a very potent enzyme inhibitor, so it's pretty safe to use with agents that have 3A4 drug interactions. It does require gastric acidity for absorption, so it does become a problem if you have a patient who is taking antacids or PPIs or H2 blockers. If they're taking antacids, it's okay to continue taking them, but they need to space it apart with the Atazanavir, at least 2 hours prior or 2 hours after the Atazanavir. If they're taking it with an H2 antagonist in treatment-naive patients, the recommendation is to use no more than 40 milligrams of famotidine, or equivalent of 40 milligrams of famotidine BID with the boosted Atazanavir, and you should give it 10 hours apart. So it's going to be difficult because if it's a BID regimen to give something, 10 hours apart, it's almost impossible to do. So they really need to be counseled on that, and that's going to be a problem because if they're taking their H2 blocker with a PI, with Atazanavir, it will decrease the absorption of the Atazanavir and potentially make it not work. And then treatment experienced patient, the recommendation is no more than 20 milligrams of famotidine. Again, space it 10 hours apart. PPIs, this was changed a few years ago. You can use PPIs with Atazanavir now in treatment-naive patients, and the recommendation is no more than 20 milligrams of omeprazole BID, Q-Day. So if they're on omeprazole BID, it's not recommended to do that with the boosted Atazanavir, and it is recommended 12 hours apart. So again, it's going to be a problem because they have to space it apart. What I usually tell them to do is take one at night, one in the morning, to try to remember that as best as I can. And then treatment experience, don't use boosted Atazanavir with a PPI at all. So fluticasone, again, adrenal suppression with that if you use it with this PI. Atazanavir must be pharmacoenhanced if you're using it with the efavirenz or tenofovir. I found this one study looking at Ritonavir, boosted Atazanavir, and quetiapine drug interaction. And that this patient had increased adverse events, weight gain, serotonin, mental confusion. So if you see an atypical antipsychotic, quetiapine, or a mood stabilizer that's being used with this, just be aware of that. Darunavir is pretty well tolerated. We've had quite a few years of experience with it now. It's recommended that this one be taken with food. The main limitation or problem with this one is it does have some drug interactions, anti-arrhythmics, ergots, some benzos, antiepileptics, carbamazepine, phenytoin, phenobarbital. Do not administer Darunavir with boosted lopinavir or sequinavir. So again, if you're using Darunavir, don't use it with the dual PI regimen. And if you're using Darunavir with efavirenz, just be cautious with potential drug interactions. Tipranavir never really hit the market very well. We had some experience with it when it was in clinical trials. Patients didn't really like it. Part of the reason was the alcohol, and then the other part of the reason was it had quite a few drug interactions. So nowadays, I don't think there's very many patients that's on Tipranavir. I think at the VA we have less than a handful of patients on Tipranavir, just because it never really got accepted by the patients. So I'm just going to skip over that. And then lastly, I want to touch on Enfuvirtide. I don't know how many of you have had experience working with Enfuvirtide, the fusion inhibitor. It's metabolized by hydrolysis. Co-administration of Enfuvirtide and the Ritonavir Tipranavir results in significant increase in the Tipranavir trough levels. The main problem with the Enfuvirtide, for those of you who've used it, it's the injectable, right? You have to give it sub-Q, twice a day injection. And there's been question of whether it alters insulin absorption. So what we do when we tell our patients is we tell them to alternate sites, and if they're giving their insulin injection at the same time or around the same sites as their T20 injection, some speculate it actually may alter the insulin absorption, because the T20, after they give their cells the injection, causes these little bumps or knots in their belly. Usually it goes away, but after several weeks. We try to tell them to kind of rub that site really well. Sometimes warm compresses help with those little knots, but if they're giving themselves insulin injections, then right after that and right in that same area, it could alter the absorption. So we've had quite a few patients on T20 injections over the years. However, just because it's a twice a day injection, it's a little difficult for the patients to do, and that rarely do they stay on it for a very long time. We try to reserve as a salvage regimen, obviously, but we still have a few. We have some patients on it. Cell Sentry or Maraviroc drug interactions. The trick with Maraviroc, I don't know how many of you had experience using Maraviroc. Besides the profile assay you have to do, before you put your patients on it, is the dosing. It's a little tricky dosing depending on what you're using the Maraviroc in combination with. So if you're using Maraviroc with a PI or Dilaverdine, not very many people use Dilaverdine anymore, but if you are using it with the PI and the Maraviroc, the recommendation is to dose 150 BID. However, if you're using it with an NRTI or Nevirapine, then the recommendation is 300 BID. And if you're using it in combination with the Favrins, in the absence of a PI, or Etravirine, the recommendation is 600 BID. So it's a dosing scale depending on what you use, which agent you're using it with. Etravirine or Intellence. It's intended for treatment experienced patients. However, I know we're starting to use it sometimes in naive patients as well. This does work as an inducer at the 3A4 and an inhibitor at the 2C9 and 2C19 isoenzyme systems. If you're dosing it with Ritonavir, if you're using it, dose it with Ritonavir if you're using it with the PI. Avoid the high-dose Ritonavir, which we don't really use anymore. There are some drug interactions, but there's really no recommendations for how to handle these drug interactions with Etravirine. There is, a 37% reduction in the area under the curve of Etravirine if you're using it with Ritonavir. But again, the company doesn't offer any recommendations on should you increase the dose by a third or what do you do with that. There's no recommendations there. And I think this is pretty alarming. Area under curve of Etravirine, it's increased by 85%. If you're using it with Lopinavir or Ritonavir. But again, there's no dosage recommendations for that. Avoid with Tipranavir, Etravirine. Avoid with Fosamprenavir. And then avoid using Ritonavir, Atazanavir, because it actually can decrease Atazanavir levels. So again, this agent, I think, has a niche. It's got little intricate detail things about it that, may prohibit its general use because of some of these details. But I think this agent has a little niche, and you may find a patient that may require an agent like this. Etravirine with other medications, you need to monitor the INRs closely. It does interact with warfarin, so if you have a patient on warfarin, just be careful with that. Avoid use with anti-epileptics, and then azoles also cause problems with Etravirine. With other medications, dexamethasone, Etravirine interacts. Statins, again, if you're going to use a statin, pravastatin, rosuvastatin, fluvastatin, simvastatin, lovastatin. It interacts with the statin, so you got to be careful with that. Immunosuppressants, narcotics, and phosphodiesterase inhibitors also interact with Etravirine. Raltegravir, Icentris, it's metabolized through the glucuronidation process, so it doesn't really affect 3A4. Induces of drug metabolism. Rifampin decreases Raltegravir levels, so it's recommended. In one study, I found to increase Raltegravir to 800 BID if you're going to use it with rifampin. And then other things that interact with Raltegravir, phenytoin, phenobarb, efavirenz, nevirapine, Etravirine, and then again, St. John's wort. If you have a patient who needs an anxiolytic and may have potential drug interactions, try to consider short-acting agents. So lorazepam and oxazepam are probably your better benzos to use. Try to avoid long-acting agents like triazolam and midazolam. And then, you can use buspirone if you need an anxiolytic. And then alprazolam should be used cautiously if you have a patient on ritonavir. So the key is, I think, use a short-acting agent if you have to use an anxiolytic. For antidepressants, they're usually pretty safe in this patient population. We have quite a bit of experience using SSRIs. In this patient population, they seem to work okay without too much potential drug interaction. If you have a patient on ritonavir, there is some drug interactions with SSRI. So my key is if you're going to start someone on SSRI, just start slow. Start them at maybe half a dose, or they may be a little more sensitive to it. Some antiretrovirals may potentiate tricyclic activity, so they may have an increased or pronounced anticholinergic effect, so just be careful with that if you're using tricyclic antidepressants. Trazodone may require dose reduction when used with boosted PIs, ritonavir boosting. So again, if you're using trazodone for insomnia or mood or anything like that, just make sure you start slow. And then dicipramine should be avoided altogether. It has a rather long half-life to begin with, and if you're using it in this patient population, some studies have shown that the half-life can increase to about 60 hours. So they'll be sleeping for days. So you probably want to avoid it. Make sure you avoid it in this patient population. In terms of psychotropics, they're usually pretty safe with this patient population. If you have any questions, again, I'm going to give you a couple of references at the end to refer to for especially some of the newer psychotropics that are on the market, the atypical antipsychotics and that sort of thing. Anticonvulsants, the newer anticonvulsants, gabapentin, pregabalin, lamotrigine, tiagabine, and levetiracetam are pretty good. They don't interact with the agents that in HIV patients. The older agents, however, phenobarbital, phenytoin, carbamazepine, and valproic acid, can interact depending on what agent you're using. So for each of these, I would advise that you look it up and just to make sure. In valproic, they've been shown to increase in viral load. So there's been HIV failures because of patients being on valproic acid. For hypertension, if your HIV patient's hypertensive, there's no significant drug interactions. Typically, you can use a diuretic, a beta blocker, calcium channel blocker, ACE, ARB without much problem. The one that I found they did say to avoid was Bepredil. It's a calcium channel blocker, or Vascor. In HIV patients, you should avoid this calcium channel blocker. For antiarrhythmics, do not use in ritonavir boosted regimens. Amiodarone interacts. Econide, flecainide, propafenone, and quinidine, they all interact. So avoid it. If ritonavir is present, do not use any of these. And I think I touched on this. If you're using anti-lipid for increased LDLs, you want to use a water-soluble statin or a renally cleared statin. So the ones to use are pravastatin and fluvastatin. If you need a more potent statin because your patient's LDL is really high and you can't get them to goal with the pravastatin or fluvastatin, rosuvastatin can be used, but be careful. Again, I usually start pretty low, like 5 on rosuvastatin if I have to use it because of the drug interaction. For hypertriglyceridemia, gemfibrozole fenofibrate can be used. They're okay with HIV infected patient fish oil. We always forget about fish oil, but fish oil is a potent agent for triglycerides, and it's benign. So if they can take it and tolerate it, don't forget to offer fish oil too. And the niacin appears safe. The sustained release product may be the preferred agent due to reduced incidence of hepatic dysfunction and increased serum glucose. Erectile dysfunction. This is commonly a problem in this patient population. They always come in, they want their sildenafil or vardenafil or tadalafil. Just make sure you reduce the dose. Sometimes half, sometimes even a quarter is all they need. So for sildenafil, instead of the 50 milligram, start them at 25. Vardenafil, which is the one that has that's the Levitra. 2.5 is what's recommended. I usually start around 5 on that one. And then tardenafil, 10 milligrams. So start at like half a tablet to a quarter of a tablet in these patients. And then anti-neoplastic agents, irinotecan has been shown to interact with Atazanavir because it inhibits the UGT1A1. And then also I thought of Ritonavir because of UGT1A1, but I couldn't find anything in the literature about that. But it uses the same mechanism for metabolism. Antifungals, posaconazole increases Atazanavir levels. You may see more of the hyperbilirubinemia if you use the Atazanavir with posaconazole. And then posaconazole can also increase the Fabrin's area under the curve about 50%. However, there's no recommendations for dosage adjustments. For herbals, we mentioned St. John's wort, we mentioned garlic. Ginkgo biloba is another one that can interact with the Fabrin's and decrease the Fabrin's concentrations. And then other things, sometimes, we forget about other things like milk thistle. People that have liver disease, I know they like to take milk thistle. Grapefruit juice is another one. Grapefruit juice contains bioflavonoids, and the one it contains is narginin, which is a bioflavonoid in grapefruit juice, and it actually interacts with a lot of the drugs that we give them for HIV. Even spacing it apart doesn't do it any good because the metabolite of narginin can be around for about 72 hours. So, they should not drink grapefruit juice at all. It's not merely just spacing it apart from when they're actually taking their medication. And then other things like ginseng and skullcap, because people are taking this stuff, all the time for immunity boosting because they're HIV. They think anything over the counter that they purchase that says immunity boosting actually helps them. But if they look, a lot of them have like ginseng in it and things like that. And then also sleep aids over the counter. Some of the herbal sleep aids over the counter have ginseng in it. So just keep that in your mind when you're talking to your HIV patients about potential drug interactions. And then I thought of an interesting phenomenon with recreational drugs, because a lot of our patients may still be drug users and things like that, and we don't have a lot of data on this because I ran a search and there isn't a whole lot of published information. But things like ecstasy and poppers and meth and all of that, I mean, there's probably drug interactions there as well with some of our HIV patients, but we really don't know the impact of that with our so reason why a patient is failing their HIV regimen, besides not taking it, obviously there could be other reasons because of drug interactions and things like that. And with that, I just want to close with the two sites I referred you to. One is www.hiv-druginteractions.org, and the other one is HIV-Insight, INSITE.org. And both of these sites have very good information on HIV drug interactions. One of them, I think it's this top one, you actually type in the name of the drug, HIV drug, and then non-HIV drug, and it just tells you what type of drug interaction there is. So with that, I'll close and take any questions or comments.